Well, welcome to the webinar. This is a webinar on fetal alcohol spectrum disorders. I'm Dr. David Wargowski. I'm a professor of pediatrics at the University of Wisconsin-Madison and in the Division of Genetics and Metabolism, and we'll get a chance to talk about why that makes sense in a little bit. For those of you who've signed on, welcome. Do know that there are 2 more webinars in the offing. If you're interested in participating, please contact Lindsay Peterson to register. For this webinar, if you have comments or questions, please put them into the Q&A box, and we'll look at them near the end and try to get to as many of them as we can. Also, at the end, please take a moment to complete the post-training evaluation that helps us be sustainable. So appreciate that. So we'll start with this question because this is, especially for people in the healthcare field and particularly those who provide care for women, this question is bound to come up. In fact, it came up last night at a farewell party for a colleague. And it really goes around a couple of issues that I'm gonna contrast in the next couple of slides. First is that everybody pretty much has heard or knows in one way, shape, or form that women who are pregnant should not consume alcohol. In fact, all of these agencies, the American Academy of Pediatrics, the CDC, American Congress of OBGYN, family physicians, and other government agencies that deal with substance use and mental health services all have invested a lot of money and a great deal of time and educational effort on this issue. Many states, in fact, also have laws that, if they're enforced to the extreme, can be used to force women into treatment or incarcerate them if they continue to use drugs or consume alcohol during pregnancy. So this is an issue that has gotten a lot of attention at the federal agency level and from a legal standpoint. Now, on the other hand, a few years ago, there were a series of articles that was published out of Denmark and the UK that showed that children who were in early childhood or in early school years who had been exposed to small amounts of alcohol in utero did at least as well, and by some measures better than, other children in their peer group that had not been exposed. And so this sparked a firestorm of backlash. People citing oppression by the medical community and unjustified blaming and shaming of mothers, and generating unjustified anxiety during pregnancy. Notably, Dr. Emily Oster published a number of articles, including this one in the Wall Street Journal, that generated a lot of media attention. So what gives here? So the objectives of this are really to talk about the whole range of potential neurobehavioral and physical effects of prenatal alcohol exposure. And then we're going to talk a little bit about facial anatomy, just to emphasize the 3 cardinal facial features or dysmorphic features that are associated with prenatal alcohol exposure, because those are important for clinicians who are doing diagnostic assessments. And then we're going to look at the range of factors that contribute to the range of potential effects of prenatal exposure to alcohol. And once we have that, we'll talk about risk as it applies in this context and come back to that initial question that I posed in the very first slide. So this is an illustration of the concepts related to this. Fetal alcohol spectrum disorders is not really a diagnosis. It's a concept term that covers a number of specific diagnoses, which are labeled here sort of under the umbrella. Fetal alcohol syndrome is the most widely recognized and in some ways the most well-known, but not necessarily the most common. I'll spend a little bit of time on that. We're not going to go into great detail on the others. But the point of this is that there is a range and that we can subdivide that range of effects in different ways in order to better understand the effects on any particular individual who has been affected by the exposure. So why is this relevant? Why are we bothering to generate all this information and spend all this agency money on education efforts? So from a clinical standpoint, prenatal alcohol exposure is the most common preventable cause of intellectual disability and behavior problems. I'm going to put that in a sort of numerical context in a minute. Important is that these effects are typically lifelong because this exposure causes a developmental injury to the brain. And so from that standpoint, the effects actually have more impact than exposure to many other teratogens that get a lot more attention, including cocaine, methamphetamine, marijuana, heroin, and this has been known for quite some time. And generally, and there certainly are exceptions, but generally exposure to those agents are very important for the neonatal period. But in most instances, if children are raised in a nurturing environment, the effects of those exposures tend to dissipate by the time they're ready for school. That's not necessarily true and not usually true for prenatal alcohol exposure. Another way to look at this is to compare it to other syndromes and conditions that, at least in the genetics world, we think of as fairly common. So Down syndrome and cleft lip and palate, spina bifida are held up as some of the most common birth defects that occur around 1 in 1,000 live births. Autism now is, of course, and deservedly so, receiving a tremendous amount of attention, and based on the most recent numbers, occurs in about 12 to 14 per 1,000 children. So fetal alcohol syndrome, so remember, just one component of the range under that umbrella, in recent studies has been shown to occur in 6 to 9 children per 1,000. And when you look at the whole range, it's 24 to 48 per 1,000, or 2.5 to 5% of school-age children. So what are we talking about here in terms of the effects that prenatal alcohol exposure can have? The primary ones have to do with neurobehavior. And those can be broken down into categories different ways, but we'll look at 3 main categories. And the first is the neurocognitive effects. And the most common way that these are identified is by measuring a low IQ, or in younger children where that isn't yet a possible thing to assess, just by recognizing developmental delay. But it can be more specific than that. It can involve executive function deficits. Now, executive function is basically how thinking is organized and how activities are planned, sort of how you get through your day logistically. Most of us do that without really thinking about it, but many people that have effects from prenatal alcohol exposure have a lot of difficulty in this area. So, for example, telling somebody that they need to be at work by 8 o'clock the next morning doesn't necessarily mean that it will happen, and many times they'll need guidance in order to figure out how to make that happen. But in addition to impaired learning, other specific areas like memory or other very specific areas in learning disabilities can be disproportionately affected. Motor disabilities are also quite common, and they're important, especially in younger children, because they're often the first way that developmental problems become manifest. And so even though they may not be the most important effects over the course of someone's life, they can be early clues that are important. So the learning and memory problems many times lead caregivers and educators and others that are involved with the care of these individuals to the mistaken assumption that the child is being defiant or willfully disobeying, rather than having a genuine developmental difficulty understanding what they're being expected to do. It's the can't versus won't error that comes up very often in this situation. Problems with self-regulation also feed into that. Now, in infants, that can show up as difficulty with self-soothing or sleep. As kids get older, problems managing their mood and behavior become more manifest. Attention problems come to the fore as well, and many children appear to have attention deficit disorder. Some children who have prenatal problems from prenatal alcohol exposure do have ADHD, but others have attention problems that are different from ADHD, and especially have problems shifting attention. So it's not as much a problem with focus as it is from moving from one activity to another. And what seems almost like a distinction is that many individuals with prenatal alcohol exposure have difficulty with impulse control. And this is tremendously important when we're looking at behavior, particularly in older individuals, so that even when they understand right and wrong and come to learn what they should and should not do, sometimes they have no control over their actions because they act before they're able to think about what they're doing. So these can affect social skills, learning, and also later on in childhood and adulthood, interactions with society in general. The other is looking at adaptive skills. So in delayed adaptive skills, these can manifest with communication problems, especially in social interactions, and particularly with understanding idioms or jokes, especially sarcasm and things with double meaning. Thinking tends to be very concrete among individuals with effects from prenatal alcohol exposure, and this leads to all kinds of difficulty, certainly with learning, but again with social skills, with self-care and daily living skills become impacted by these difficulties with adaptive learning. And this can also have some effects on motor issues in younger children. There are lists of secondary disabilities that were originally developed by Dr. Ann Streiskouth in the late 1990s, one of the pioneers in the study of the developmental and behavioral effects of prenatal alcohol exposure. This is a partial list, but I think highlights some very important characteristics and problems that can arise later on in the lives of individuals with fetal alcohol spectrum disorders. Part of the idea of calling these secondary disabilities is that they come on later, but the other part is that there's an implication that they might in some way be preventable. So I'm not going to spend time on each of these. But for example, inappropriate sexual behavior and promiscuity in this population often has a developmental basis. And even though it's a lightning rod, and even though this is a very serious set of problems, by recognizing the developmental basis of this, it gives us an opportunity to intervene before they become manifest and to help work with affected individuals at earlier ages. And that's sort of a paradigm for a lot of these. If we understand the developmental basis of this particular type of brain injury and identify ways to intervene, we can help tremendously these individuals become more successful at home and at school and in society. This slide correlates many of the regions of the brain with the effects that I've been outlining and many others. But really the point of it is not the detail. The point of it is that prenatal alcohol exposure, when it does have effects, tends to have global effects on brain development. And so this can show up in highly variable ways. The assessments and the interventions that are designed for individuals with FASDs really need to be individualized using the knowledge that we have about the potential effects of that type of injury. I mentioned physical effects, and we won't spend a lot of time on this, but these are usually not the biggest problems that individuals have in terms of their functional ability, but they do allow clinicians to identify these characteristics, and that helps us know that prenatal alcohol exposure is in fact the cause of the problems that they have. So they're very useful diagnostically. Most of the diagnostic criteria that are in use pay some attention to growth deficiency, and the National Task Force on Fetal Alcohol Spectrum Disorders several years ago chose the weight or length at or below the 10th percentile, either before birth or after birth, at any point in life as a criterion for growth deficiency. All the criteria, one way or another, look at structural brain abnormalities, again, most often a small brain overall, which is reflected in a small head size or small cranium. But there are other specific structural abnormalities that have been more correlated with prenatal alcohol exposure, particularly structural abnormalities in the corpus callosum. And some of these are quite subtle and just result in a small, minor change in the size or structure of the corpus callosum. The cerebellum, basal ganglia, other areas of the brain are particularly noted. But again, when we see effects on brain structure, most often it affects it involves the entire brain. From a morphologic standpoint, in other words, the way that we look at these individuals from a genetics perspective is to look at the physical characteristics that we know to be relatively specific to prenatal alcohol exposure. And in particular, the palpebral fissures, which are the openings of the eyelids, can measure the length from corner to corner, and generally individuals who show outward physical effects often have short palpebral fissures. There are standards for this that we can use in the field diagnostically. And again, the chosen threshold is at or below the 10th percentile. The philtrum is this groove between the nose and the upper lip. Most of us have some degree of ridging there. People that have a very smooth philtrum have characteristics that go along with prenatal alcohol exposure. The vermilion border is the red part of the upper lip. That often is quite thin. Now, All of these characteristics can occur in other conditions by themselves, but when they all occur together, there's relative specificity for, in this case, fetal alcohol syndrome, but we can also look for these characteristics in other diagnoses and other manifestations under that FASD umbrella. So why are these facial characteristics there? Well, we know a little bit about the embryology of the forebrain and the middle part of the face, what we call the midface. We know that in other developmental disorders, there's often a link between developmental abnormalities of the forebrain and developmental differences in the middle part of the face. So it makes sense that if there's an agent like alcohol that's toxic to the developing brain, that it would also show manifestations in the middle part of the face. And in particular for the eyes, we know that the eyes develop as outgrowths of the brain. And so anything that affects the brain development may very well affect eye development and lead to smaller palpebral fissures. So there's an embryologic basis for the facial features that we see in individuals who are affected by this condition. So let's take a little bit of a step back to a higher look at this and ask this question: what is the evidence that prenatal alcohol exposure is harmful? Well, it turns out that there is a ton of evidence from not only human clinical studies, but animal studies in a number of different species and also basic science studies. And the bottom line for all of this is that they all add up to confirm the many roles that alcohol has in disrupting embryonic and fetal development, particularly in the brain. And the findings are remarkably consistent across species. Now, here's an example of that. So in the upper pair of pictures, we show a child with normal facial development next to a scanning electron micrograph of a mouse embryo at an age that corresponds to the 3rd week of human development. And in the image in the upper right is of a normal mouse embryo. And you can compare both of those to the images below that show on the left a child who has very characteristic facial features of fetal alcohol syndrome, and then on the right, a mouse embryo the same age that you can see the small eye openings and the very smooth philtrum below the nose. So even in different species, we can demonstrate the same developmental abnormalities as we see in individuals with fetal alcohol syndrome. So when we turn those physical characteristics into diagnostic criteria, this is one set of diagnostic criteria that's in wide use. And so we look for those facial anomalies, and we'd like to see at least 2 of the 3 cardinal facial features in order to feel that those characteristics are specific enough to attribute them to prenatal alcohol exposure. The growth impairment, as I mentioned, and then something different reflecting a problem with brain development, either a problem with brain growth or structure or the way that it functions and the way that that is manifesting the child's development and behavior. So all of this kind of runs up against life experience that many individuals have who know individuals who drank heavily during pregnancy and their children seem to have turned out okay. I've also, as described earlier, that there's a wide range of effects. So what is it that makes the difference? Is it good nutrition? Is it good genes, genetic background, or is it just pure good luck? And I want to look at those individually and together and put this in the context, or put the effects of prenatal alcohol exposure in a bit of a broader context. So from traditional looks at teratogenesis, that is the science around the effects that extrinsic agents can have on a developing embryo or fetus, we know that dosage is important, and certainly the amount of alcohol consumption correlates with that and correlates with the severity of effects and the specific effects that occur. Timing during gestation is important. We know that the morphologic effects, the physical effects are more likely to develop after exposures early in pregnancy. But the brain continues to develop throughout pregnancy, so exposures at any time can affect brain development. There is an evolving model of teratogenesis, however, that incorporates maternal nutrition and other extrinsic factors that come into play. We're also starting to understand that there's an important interaction between the genomes of the developing embryo and fetus and of the mother. We don't have a complete understanding of that yet, but looking at models and other disease processes, it's very likely that this is going to turn out to be an important overall factor in determining the severity of the effects. And this gets us into an evolving science of epigenetics. and looking at how genes are regulated. So it's not just whether or not a gene contains a mutation, because in fact alcohol doesn't mutate genes. It's not a very potent mutagen. But alcohol has tremendous effects on gene regulation, when genes are turned on, when they're turned off, how efficiently they function at the right time. And so this is now a tremendous avenue of research in trying to better understand how alcohol can result, a given alcohol exposure can result in such a wide range of effects, including in some individuals, no apparent effect. So this gets us in then back to that original question. And I want to frame this in terms of risk. So traditionally, we use the term risk and probability interchangeably. And a lot of people do it, I do it, it's actually a mistake. Probability is a mathematical concept. Risk incorporates that along with the severity of the concept, or the degree of harm, which is much more subjective. And so different degrees, but in addition to the subjectivity of the degree of harm, different levels of probability have different sort of meaning to different individuals. So there's a certain subjectivity to risk that isn't really there for probability. In regard to prenatal alcohol exposure, we know that the potential harm is substantial. So that element of risk has a high mathematical value. But the probability that any given exposure will cause harm is unknown. So there's a big question mark in terms of risk for any given pregnancy. If we look at that, if we think about that and look at the traditional public health message about prenatal alcohol exposure, which is still very valid because it reflects what we don't know. There's no safe time to drink, there's no safe type of alcoholic beverage, and no amount of alcohol that is known to be safe to consume during pregnancy. So the nuances of that are important, and the word known in the second line there is very important because what it reflects is that we don't know how much alcohol is safe, especially in any particular pregnancy. Now, if we think back about the information I gave you earlier, and that many of you have heard about studies showing that maybe a little bit of alcohol use during pregnancy might not be so harmful, the reality is that we don't know when it is and when it's not, or in whom it is and in whom it might not be. So a more sort of informed message that relates to prevention is this. What we know is that drinking alcohol during pregnancy has the capacity to cause serious lifelong problems in an exposed embryo, fetus, and future child. We don't know why some exposed children are affected and others are not, or what the chance is that that's will happen in your pregnancy. So the message is now, here's what we know, this could happen, and do you want to take that risk? And that actually gets us back to talking about a very important issue that underlies all of this, and that is stigmatization of pregnant women and mothers, especially mothers who have affected children. And so, again, what do we know? We know that 50% roughly of pregnancies are unplanned. We know from data that the CDC collects periodically that fairly consistently over several decades, women in what is defined as the childbearing years 18 to 44, about 50% of women nationally drink during that age range, and it's much higher in some states like Wisconsin than it is in some other areas of the country. We know that drinking during that age is a risk factor for unintended pregnancy, and if a woman is drinking and becomes pregnant, doesn't know she's pregnant, and continues drinking, you have an alcohol-exposed pregnancy. This is a very, very common scenario. Prenatal alcohol exposure happens. Prevention campaigns are very important, but it's unlikely that we'll ever be able to completely eliminate this scenario from happening. It's also true from what I told you earlier and from many other things that many of you have heard that there are mixed messages in the popular media about alcohol use during pregnancy. And then when you get at the higher end of the risk strata, people that have alcohol use disorders who have very high alcohol content intake often do not have control over their drinking. So when you look at all of this, there's really no rational basis for blaming mothers for, quote, doing this to their child, close quote. I've never heard a mother say that she did this to harm her child, and that's just not really part of the life experience of people who deal with this issue. So I believe that is the last slide, and we'll end there, and let me take a look at the questions here. Okay, so one question, would binge drinking at key stages of fetal development cause any of the disorders on the fetal alcohol spectrum? So I kind of got into that a little bit there at the end. Timing is certainly important, and particularly in regard to the physical outward physical manifestations. So again, those tend to occur with exposures earlier in pregnancy. But even for that, it doesn't tell the whole story, because sometimes early exposures do cause those characteristics and sometimes they don't. The most important thing about timing is to understand that brain development continues throughout the entire period of gestation and beyond, so that really exposure at any period during pregnancy has the potential to cause the neurobehavioral problems that we worry about most. Second question is a very important question: how much alcohol use is considered alcohol exposure to the fetus? When we use the term prenatal alcohol exposure, by definition, that really talks about any exposure to alcohol. Now, that doesn't mean that any exposure to alcohol would be expected to cause fetal alcohol syndrome or any of the problems that I've just outlined. And the reality is that we don't know what the safe level is, and that's kind of the whole point of looking at this from a risk perspective. People have been studying this very, very hard for a long time and have never been able to find a level that can consistently be regarded as safe. There are a number of different definitions about low risk versus high risk drinking, and I didn't go into those. There's a whole science around that. The most important message is that for any one pregnancy, we don't really know what is a safe level. So I thank you for your attention, and please, again, take a little bit of time to fill out the post-training evaluation, and thank you for joining me.